So I do want to introduce Dr. Banter Green. He is the director of the University of Washington Center for Community Engaged Drug Education, Epidemiology, and Research at the Addiction, Drug, and Alcohol Institute for the University of Washington. And my connection with Dr. Banter Green came from work in a conference, Transforming Our Communities, which just took place this week. And we had an excellent local community conversation here in Okanogan County. And so really want to thank you for coming and speaking with the Okanogan County CHAC. We really appreciate it. And yeah, so Dr. Banter Green will be sharing with us about the Blake Bill, giving us a 2021 breakdown, a little bit about what happened in 2023 and his perspective on why. And then we'll dip into local community conversation for breakout.
Great. Thanks for having me. So I've done addiction work for a long time, and it has never been as, I don't know, much like an avalanche or a waterfall as it has been the last few years from a policy perspective. Almost 2.5 years ago, the state Supreme Court unexpectedly in February 2021 issued the Blake decision, which defelonized drug possession in Washington state. Drugs were legal for about 3 months in early 2021. The legislature responded, made drug possession a misdemeanor, subject to diversion for the first 2 arrests to the LEAD program, which was called Law Enforcement Assisted Diversion, to refer people into treatment. Didn't fund any of that treatment, which is major oversight. Basically set up, basically opened a big front door to not much, de facto. And also created a committee, the Substance Use Recovery Services Advisory Committee, to make recommendations to the legislature about the treatment and harm reduction systems. And I, luckily, was named to that committee and worked with Alexia Orr from FIRE. We were co-chairs of the treatment subcommittee. And so that committee came up with, I think, 17 or 18 recommendations to the legislature on sort of the prevention, recovery, harm reduction, and treatment fronts. What I was going to do was share with you primarily the recommendations on the treatment side. I can talk a little bit about the harm reduction side as well, talk about all of it, but I will focus those comments a bit. And then just also for context, my roles in all of this, you know, I'm faculty in the Department of Psychiatry and Behavioral Sciences and Public Health here at the UW, and I have been on the state opioid overdose response work group since June of 2008, so for a little while, and I'm actually one of the 4 executive sponsors of Washington State's opioid response plan. All of that matters because our group of 4, another thing that happened in parallel was the opioid settlements, right? All of that $500 million coming to the state, but by the way, over 18 years, split half between the state and local. So it's a lot of money, but it gets pretty small pretty quick. So that's happening in parallel with all of this. And so I was on the group that made the recommendations to the governor. And then the governor made recommendations to the legislature, and then the legislature surprised everybody at 11:59 on Sunday night when they took a left turn. So it's been a really exciting few years. Opportunities for personal growth have abounded. I'm going to share with you, besides my little bit of snark today, I'm going to share with you a little bit of more concrete background, and happy to take any questions, conversation, discussion. I have until about 1:30 or so. So what I want to share with you are the treatment recommendations out of the SRSA committee. So this came from this Blake bill, Senate Bill 5476. It created this committee. Let me make this full screen. And I just want to share with you the high-level recommendations we made. Again, Alexia is my co-chair on there. We met a lot. This was much of last year, and we had about 60 different people at the meetings over time from all of these different perspectives. And I just want to share this. There was it's one of these that is a state-run process that is supposed to incorporate people with living and lived experiences into it, and it didn't go very well. There was a lot of tension, but I do feel like there was a fair amount of those voices were still heard. And I still think they were still present. We still use them to try to inform practice. So it was a challenging process, but I think ultimately a reasonably good one. So the reasons for the recommendations, I just want to say, and how we consider them were, so the bill mandated the committee to provide for continual, rapid, and widespread access to a comprehensive continuum of care that will be provided to all persons with substance use disorder. So that was the mandate for this committee. There are large treatment gaps. They made a recovery navigator referral program. There are big gaps geographic. I don't need to tell you because of where you all are. A small minority of people are accessing care, whether it's opioids or stimulants, which are the areas that I work on and which are responsible for the vast majority of mortality. There's at least an 80% treatment gap. And I just will note here for background, it's not just that there isn't enough of treatment, it's that the care models are incomplete. I did my training in specialty addiction treatment. I then did a lot of work trying to expand treatment access into the healthcare system. We thought that was going to solve all of our problems. It didn't. We still have an 80% treatment gap. So a lot of our work is about reducing barriers and engaging people on a drop-in basis to whatever care they want. And so you'll see that coming in here. Again, that's the point here around desirable services, settings, and models. We often say people don't want treatment. And I think what people don't want is treatment that has been ineffective or in fact traumatizing to them in the past. That's different than saying they don't want help reducing or controlling their use or having better health outcomes. So really urgent public health needs. And I should note here, this is drug poisoning deaths in Washington state, basically a doubling between 2015 and 2021, which is just unprecedented. It was almost a doubling in 3 years. And that was a combination of methamphetamine and or fentanyl, meaning illicitly manufactured. Fentanyl is a very strong opioid. So dramatic changes in the public health. So the recommendations we focused on were health engagement hubs. These are all-in-one locations where people who use drugs can access medical, harm reduction, and social services. This addresses multiple points of the state plan and also draws on work we've been working on for a long time on the opioid overdose response plan, and also builds around low barrier care that my group has been researching for 6 years and implementing in 6 sites across Washington state. So this idea of a health engagement hub, just to share with you, this is in some ways nothing new at all. 3 blocks from where I am, University District, my dad was a volunteer doctor at the Open Door Clinic in 1968, where 80% of the people who came into that clinic had substance use disorder. 80% of what they worked with on them had nothing to do with substance use disorder, had to do with healthcare, mental health, housing, social supports in their life and such. And New York State, in fact, has a very similar model that has gotten some approval from Medicaid for funding. So a new model of care and health engagement hubs for people with substances, essentially drop-in care. These are generally initially affiliated with harm reduction programs. Harm reduction, to be clear with folks, is both sort of supplies, things like naloxone kits, safes, or syringes and such, but also really very importantly, an attitude. It's a place of engagement. In my work with people who use drugs over the past almost 3 decades, everybody wants harm reduction. Some people want healthcare, some people want treatment, but everybody wants harm reduction. So if you are offering healthcare or treatment, you're not offering harm reduction, you're not offering something for everybody every day. So we're really trying to expand it because we want people to come in. We want people to be engaged. So the idea is that it should be located with harm reduction programs. From services programs are the most obvious example of that, as well as other types of sites. And the services should be really, really comprehensive. I won't go into all of it now, but it's healthcare, it's behavioral healthcare, it's wound care, it's mental health. It's also aspects of spirituality and emotional support. So this is also really important. It's very important for you. One of our biggest advocates in the meeting is from Walla Walla and sort of Southeast Washington. And that is that for some models of addiction treatment, you have to get a specialty assessment that might take 2 to 3 hours. And that could be a barrier both in terms of time, but also accessibility. It might take you a month to get that assessment. Well, as a person who has worked in the treatment and healthcare systems, social workers, nurses, physicians, they can do that same assessment that it's essential to start care within 15 minutes. So we're working with the state, and this recommendation did go forward to change that initial engagement and measurement so that it is enough to start care immediately. And that has to do with both diagnoses and then a determination of medical necessity, which is what insurers need to actually start paying. A nice big psychosocial assessment might be helpful, particularly if the person wants it, but it also could be a barrier and could really be prohibitive for folks. So that initial assessment thing sounds like an inside baseball thing, but it's actually really, really important. Expanding access to opioid treatment programs. These are historically known as methadone clinics. You can see where the treatment deserts are. Hey, it looks like you guys. So, it's hours to get to the opioid treatment programs. And there is an effort there to expand that access to allow more mobile access, to allow more sort of secondary services. So there's a big attempt to expand access to opioid treatment programs. The reason for that is the medication buprenorphine or Suboxone is a great medication. It's not quite as great for fentanyl. Probably the best medication as a medication is actually methadone. And that's a whole other story why that is, but pharmacologically, it's going to be a better medication more quickly for many people. So the real point is that needs to be an option also. And then also there's this idea around safe supply. This is this notion that is happening up in Canada. I think it's also fair to say that the medications buprenorphine and methadone are like forms of safe supply. That is, we have an unsafe supply of illicitly manufactured fentanyl and fake pills and powders, and we need to have safe supply. And there are different models for that. It can be a prescription model, it can be a dispensary model, and so on. And essentially, there's just a request in this proposal here to create a work group to study this. What can we learn from Canada? What does the science say about this? So what happened is these were all essentially enacted in some way. So the health engagement hub piece, there's 2 pilots that are funded, and then there's a mandate to the state healthcare authority to figure out how to fund these mechanisms, to fund this care model statewide. Our recommendation was to fund 39 of these health engagement hubs, 1 per 200,000 population. And I think we put in there also something like no more than 2 hours maximum from any location as well. And I know there's both population and geographic access issues. So health engagement hubs got a little bit of a start with a potential to expand quite a bit. There's a mandate now to actually address the initial engagement and measurement issues. There's a lot of work going on to expand that opioid treatment program access in a safe supply work group. And there is some funding from the opioid settlement dollars to do some of that. That's not in this legislation, it's actually in the budget, but there's some funding over there to do that. The other big piece is that on the one hand, harm reduction services such as drug checking, such as safer smoking supplies, the majority of people dying now are actually smoking their drugs and often don't have access to safe supplies and therefore no reason to come in for harm reduction services. So there actually was an expansion of these harm reduction services and supplies allowed statewide, and then an allowance for local municipalities to preempt that and ban those same harm reduction supplies and services. So a bit of a paradoxical thing the legislature did. So that is my whirlwind on the last couple of years. And Michelle, it would help to know like what else I can share in terms of background that would be helpful for this group, and then I'd be happy to have any conversation or answer any questions.
Yeah, thank you so much. I think if people want to drop in some questions into the chat, that would be great. I think one thing that is helpful that if you can share any information on would be regarding any kind of law enforcement or policing. I know you didn't have that in your slides, but any kind of information regarding the law enforcement, policing.
Sure. Yes, sir. Sorry. I'm right. I keep thinking public health. So just to share with you. So what happened is that in the law that passed 2 years ago, drugs were a misdemeanor. And in this version of the bill, it was raised up to a gross misdemeanor, punished up to 364 days. In the previous law, you were required to divert people the first 2 arrests. In this version of the law, you are allowed to divert. So the penalty got much higher and the ability to divert got weakened. So some of those elements are still in there, but they've been tweaked in those ways.
Thank you. That is very helpful. And I think the other piece of information that would be helpful to know or understand, we actually had Senator Shelley Short with us on the call earlier today and asked her for her perspective around the Blake bill and the changes. And so your perspective on, especially from Eastern Washington and what you saw in terms of pushback or you know, what did you hear from communities or representatives from Eastern Washington with respect to why it kind of shifted a little bit back again?
I mean, decriminalization wasn't going to happen. Like politically, that wasn't going to happen. And then the debate was whether to make a possession a misdemeanor or a gross misdemeanor. And they went with gross misdemeanor. I think the challenge is, and I testified 4 times on this bill. The 4th time was really talking about the fact that the legal response is not aligned with the healthcare and treatment response. And I just want to explain that a little bit. So what they're saying over here on the law enforcement side is, well, it's a gross misdemeanor and you can refer to diversion. And if you go to diversion, you have to complete treatment in 30 days. Well, I mean, I worked in addiction treatment for 3 decades. I can complete treatment in 30 days and make no progress in my recovery. That's a check the box. That's not meaningful. Where we were getting close to is actually engaging in services. And the idea of those health engagement hubs, that may be involving treating completion in 30 days, but I hope not. I hope it's engaging in services for years. And so we were trying to switch from this idea of a 30-day completion in treatment to long-term engagement in services. And in particular, the challenge with tying this 30-day treatment completion piece over here is that because that had criminal legal sanctions involved in it, ongoing substance use is a violation both of the treatment and the law. The majority of people, even if they opt for the treatment option, are still going to end up in jail because they're not going to become abstinent, they're not going to complete treatment. So there was a piece on KNKX today that I was part of, among with many other people, saying the governor was saying that we're not trying to fill up the jails with this bill, we're trying to fill up the treatment centers. Well, that's not going to happen. Even with the existing treatment capacity, it's inadequate, and the care model is inadequate. So really trying to go to a care model that is focused on engagement. When I was in Spokane yesterday, hard to imagine I was in Spokane yesterday, but I was, and I was talking with the panel there at the Transforming Our Communities meeting about what do they feel like we need to advance harm reduction? And what they said was drop in healthcare, wound care, and withdrawal support. They didn't say safer smoking supplies. They said healthcare, behavioral health, like those things. And the reason is that those support engagement. The reasons for people to come in and keep coming in no matter what. And that the challenge with tying the criminal legal system response to this treatment response is it becomes binary. You're good or you're bad, you're clean or you're not, you're using or you're not. Most people in the process of their recovery continue to use, whether it's a return to use or whether it's reduced levels of use, even as the recovery improves. Recovery isn't about abstinence, it's about an improvement in functioning. And so it's not a surprise. I mean, the criminal legal tool is the wrong tool for substance use. That doesn't make sense. It's a health condition. And yet we're tying it to a criminal legal system response. I know why, I know the history of that. There's reasons for that for many decades, and they're not great. And they're definitely not effective. I mean, that's the bottom line. Even if you moralistically believe in a criminal legal system response, there's no evidence it works. I mean, you can look around you. We've been trying it for 50 years. It doesn't work. So why don't we try actually expanding access to care, making on-demand care actually available to folks, and that care being what people actually want and can and will take advantage of. So that's where we're trying to shift to. And there's theoretically still some possibility in there. I think it really is incumbent upon us to work with our criminal legal system partners, because what I have found over and over and over again when I talk to law enforcement is they know it's futile to arrest people for possession, but they don't have anything better. And they often will say well, I didn't want them to overdose again, so I put them in jail. I knew they wouldn't overdose in jail, which actually may not be true, but maybe there's a lower chance of overdosing in jail. So that's why we're really trying to shift this, into a healthcare forward model of care.
Thank you, Dr. Bantagreen. And if you have time, I know you have to hop off in 3 minutes, but if you have time to answer this one question that we had in the chat. And if you don't have time, I hope you can shoot us an email and we can send it out. The question is, we see care and support dropped upon incarceration. Are there model programs where services continue? So Matt, in recovery support, through and after incarceration?
Yeah, I mean, there's been amazing strides over the last 2 to 3 years around jails increasingly offering the effective treatment medications, most likely buprenorphine, sometimes methadone or naltrexone in jails. So there's two pieces. One is getting jails to do that. And I've got a flyer somewhere. Oops, somebody took all my flyers. I have a flyer that I can send you that we basically have built for jails about why it is to their advantage for their staff to actually have medications for people in jails. It makes their job easier. You know, people are not getting incredibly ill in jail and not having to do medical transports. They can care for people there. The reciprocal part of that, though, is if you have low barrier care in the community, what we have found is that jails and emergency departments are more likely to initiate medications for opioid use disorder if they know there's a drop in place for people to follow up. Previously, the argument was, well, why would I start them on a medication? I know they're not going to show up for their treatment appointment in 1, 2, or 3 weeks. Well, that argument's gone. Now there's a drop in place they can get in within a couple of days. So those things go together. It's supporting jails and offering medications, and then also having community-based sites. We also need to be careful that jails aren't the only place to get medications. We actually had a very odd thing happening for a little while, actually in South King County, where people who had warrants out were going to the jail to turn themselves in so they could get on treatment medications. That's messed up. I mean, that tells you how messed up things are. If people are doing that, that tells you you have no system of care, but it speaks to people's needs. And so, you know, I wouldn't ask you to only build capacity in jails. There should be complementary capacity in jails, but they can be part of that. Ideally, though, you're really getting upstream of that, right? You have a system of care that law enforcement, EMS can actually refer people directly into, and that word spreads and people start self-referring into that care as well. And that's why that care needs to be not just treatment, not just healthcare, but also harm reduction services, so that there's something for everybody every day.
Thank you. A continuum of services.
Yes, a continuum of services. All right. Thank you. If you have any more questions, let me know. Michelle, if you email them to me, I'm happy to follow up.
Excellent. We will take you up on that. And
great.
Hopefully we'll get some questions in the chat that we can send over to you. Thank you so much.
You bet. Bye.
Bye. We're back. So how far did we get into did we get to the gains? Alana, did we get to gains? What did we gain?
We touched into it real quick. What the gains
are. The light tap?
Yeah.
The light tap and gains. Okay. So really, we wanted to introduce this conversation because we wanted everybody to try on this tool of complexity, this complexity spectrum. And what you all will see is that a legislative change like the Blake bill has the power to be a system transformer, but community context, how and what resources are available within community have the power to shape the impact of a legislative bill like the Blake bill. And so it can change it from a solution at scale to a system transformation, depending on how ready a community is to adapt that change or to hold on to that change. We did get, although I'm guessing that we didn't really get to dive deep into what we gained, we did gain a lot of good things. And I don't know if I have anybody from Advance on this call from the RMP, but the Recovery Navigator program was born during this time. And if you all on the call have never worked with the Recovery Navigator program, please do engage with them. It's under Advance. Advance is affiliated with Family Health Centers. I know there's a lot of communication among many social service agencies with Advance, which is great. And it meant that there was communication between law enforcement and community-based organizations, more communication than there was before. It may not be perfect yet, but what we learned right today was that system transformation, we're not striving for perfection, we're striving for improvement. We're striving for healing, we're striving for change. And so several other legislative changes were made during this time. And so I invite you all, if you have one that you want to share about, I know Elsie Cruz from DCYF had a share out as of a recent change. Please email us and we'll compile those and send those out. and kind of try this concept on, right? If you want to try to, think about this context, what is the cloud of it? What is the cloud of the change? How do we make sure that we preserve the positives of that legislative change within our community, and also learn something from the negatives or the challenges that we had in this in these changes, right? Because there certainly were challenges, but we also don't want to throw out the strengths or the gains that we had because of it. Any last thoughts from you, Alana, before we jump off the call?
I don't think so. Thanks to everybody so much for hanging in here with us today. And I hope that all of us, I know I personally just learned a lot, and some really helps me, helps inform the way I think about these networked community health issues. So thank you, everybody, for your contribution to my learning too today.
Thanks, everybody.